So good morning everyone, and I really wanted to thank the entire team at Softbones for giving me this opportunity to speak to all of you. And we truly are in unprecedented times, but I know hearing from our patients that we see here at Duke University that all of you are extremely strong individuals and have managed this time extremely well. I hope each one of you is staying safe and healthy. And I'm going to actually give you an overview from where we started to where we are today, and what the next directions are, which Denise already just started to allude to. So these are my disclosures. And the topics that I'm going to speak on today are starting right from an overview of hypophosphatasia to future directions and the important role of coordination of care. So in terms of an overview for all of you, I think can you see my slides? So in terms of an overview, hypophosphatasia is a rare inherited metabolic disease. And I want us to know that the words tissue nonspecific alkaline phosphatase, or TNS-ALP, and alkaline phosphatase, or ALP, will be used interchangeably, I think, throughout the day today, but it really means the same thing. And the mutations are in the gene which is called ALPL. So just wanted us to have the nomenclature down clearly. And the inheritance patterns will be discussed by my colleague and genetic counselor, Erin Huggins, during her session. So we also know that there's a wide range of symptoms, including multiple fractures, bone pain, tooth loss, short stature, but I want us to recognize that hypophosphatasia is beyond a bone disease. Of course, we need to get to the root cause of the problem, which here is the low serum levels of alkaline phosphatase or of TNS-ALP. So let's see what TNS-ALP does for us. And I think here again is an important aspect to recognize. So if you see here, it's playing a very important role in the making of HA, which is hydroxyapatite, which are the crystals which are helpful for normal bone mineralization. So TNS-ALP plays a critical role in hydrolyzing this mineralization inhibitor, PPI, to produce inorganic phosphate or phosphorus, and calcium and phosphorus then bind together and make the hydroxyapatite crystals, which are really important for bone mineralization. So I think the first key message is that it's very important for normal bone mineralization. And I want you to think about this word or this agent or this substance PPI, because this becomes an important aspect of the rest of our discussion and also for management and monitoring patients with hypophosphatasia. Now this is its role in bone. Let's look at the role in the central nervous system. So once again, we've got an important role of this enzyme, TNS-ALP, and in its presence, it's converting vitamin B6 or pyridoxal phosphate to pyridoxal. This pyridoxal then crosses the blood-brain barrier, and then is reconverted back into PLP or vitamin B6. So in the absence of TNS-ALP, you're not going to get the ability to have sufficient levels of PLP in the brain, and PLP is a very important cofactor for the synthesis of many brain neurotransmitters to allow for normal functioning, including an agent called GABA. So now what happens when you are missing alkaline phosphatase or you have low levels of it? So as we said, you won't make the hydroxyapatite crystals. You're going to have increased levels of PPI, and here in the central nervous system what you're going to have is a decrease in the PLP, and so this is going to lead to a reduction in what we say the important transmitters or the neurotransmitters production in the brain, which can then result in low levels of vitamin B6, and so one can have what's called vitamin B6 responsive seizures. So once again, we've just recognized that its function goes beyond bone. We've recognized its role in the central nervous system. So now let's look at this in a simplified way. For healthy bone, we need what we say in the resting state. What happens is that you have a good amount of bone resorption and bone formation. So bone resorption occurs by a process which requires osteoclasts, which are breaking down bone, and then bone formation is in the presence of alkaline phosphatase, which is what we call osteoblasts. And so these two are in a good equilibrium with each other and result in healthy bone. Now, if you're missing alkaline phosphatase or you have low levels, you're not going to have appropriate bone formation, and you end up then with fragile bones because now you've got more bone resorption and less bone formation that's taking place. Now let's look at it in the muscle. If you remember, we talked about inorganic pyrophosphate, and so alkaline phosphatase is required to break down the pyrophosphate or the PPI into phosphorus. Without alkaline phosphatase, you have a buildup of this inorganic pyrophosphate in muscle tissue, which may be really the source of pain and muscle weakness that many of you experience. Okay, now let's look at it in teeth. ALP is required for cementum. Cementum is really important to form on the tooth roots because it helps in stabilizing the tooth, and without cementum, there can be a spontaneous loss of fully rooted tooth. Many of you have experienced this as well. You have, the loss of entirety of the tooth. It's often painless. There's little to no bleeding, but it's a premature loss of this fully rooted tooth. Okay, now let's talk about it. We talk about it as an ultra-orphan disease, but I again want us to recognize that it depends on the region. There are certain genetic changes or mutations in the gene, in the ALPL gene, which are common to certain regions. For instance, Canada, Japan, Europe, and the US, we see a difference in frequency of these. And then I want us to recognize that hypophosphatasia is a spectrum of disease. I do not like the word mild to moderate, but this is how it's reported in the literature. I want to think of it as a continuum of disease, but at one extreme we can have individuals, with a frequency as much as 1 in 6,400 individuals who have hypophosphatasia, to then the more severe forms of hypophosphatasia, which can range from 1 in 100,000 to 1 in 300,000 individuals. So once again, the frequency of this disease varies by region, varies by the underlying genetic mutations, etc. Alright, now let's talk about the diagnosis in terms of signs and symptoms of hypophosphatasia. Okay, to diagnose hypophosphatasia, it really begins with you, the patient. You have different kinds of manifestations, the skeletal or the bone manifestations, the systemic manifestations. You can have pain, you can have renal complications, with the development of stones. You can have this premature tooth loss. You can have this family history of a sibling or a parent with hypophosphatasia. And often you go through a diagnostic journey or a diagnostic odyssey where the signs and symptoms of your disease are missed, and often, individuals are told that the cause of their symptoms are not really clear. Now, the key diagnostic indicators really are the root of the problem, which is the low level of serum alkaline phosphatase. But again, we need to make sure that this is taken according to the age of the individual. So age-specific low levels of serum alkaline phosphatase, and then increased levels of those substrates. Remember, we talked about the inorganic pyrophosphate or PPI, the PLP or the B6, and then another agent, which is the PEA or the I'm sorry, can you not see my screen? Excuse me, can you not see my screen? Bonnie,
No,
can
we
you
can
just...
see your screen. You're okay.
Oh, because I'm seeing some messages saying that they cannot see what I'm saying. Is it all clear so far?
Yes, you're okay.
Okay, perfect. And so I think the important message here is that the levels of alkaline phosphatase vary with age, and it's very, very important to use age-specific norms. I cannot tell you how many times cases, especially with the pediatric age of onset, are missed because what appears to be normal levels of alkaline phosphatase, it's because we're comparing it now not to the age-specific norms, rather to what is understood. Okay, now let's look at the mechanism of what goes on. So if you have a mutation in the gene ALPL, you get reduced levels of tissue non-specific alkaline phosphatase. So we measure it then in blood as a low alkaline phosphatase. As we've again talked about, you have the accumulation of PPI, which is really a potent inhibitor of bone mineralization. A very, very key message. The more the levels of PPI, the poorer the bone mineralization. And then again, another thing to remember is that when we use certain agents which are synthetic analogs of PPI, such as the Fosamax, etc., we are actually not helping our patients with hypophosphatasia. Then we've talked about PLP, which is the diagnostic marker but plays an important role in brain as a neurotransmitter. And then the accumulation of phosphoethanolamine, which is a diagnostic marker. However, its relationship to disease pathophysiology is not fully understood. All right. Now, many of you may have been told that you have or your child has the perinatal form or the infantile form or childhood or adult onset or just odontohypophosphatasia, which is just involvement of tooth. However, there are no formal diagnostic criteria. I don't want us to think about these as conditions occurring in silo because there is an overlap in symptoms between these so-called subtypes, uncertain of the age of onset, complicating the diagnosis, and patients may experience symptoms of hypophosphatasia at any point throughout the life. So again, I want us to think of it as a disease continuum. And I'm going to try and hone in on this one more time. So these are some of the systemic manifestations noted in children with hypophosphatasia. Again, skeletal, central nervous system or neurologic, tooth or dental, muscular, kidney, and then there's significant disease burden because of surgical intervention for fractures, fatigue, difficulties in walking, need for physical therapy, occupational therapy, and use of assistive devices. As far as kidney, it could be the nephrocalcinosis or the appearance of stones, the high levels of serum calcium, spilling of calcium in the urine, and in terms of rheumatologic or muscular, is this muscle pain or weakness, which I said could be really related to the higher levels of inorganic pyrophosphate or PPI, and then the neurological, which can be looked at as an increase in intracranial pressure resulting in headaches, difficulty in blurring of vision, optic nerve damage or damage to the nerve which helps us with vision, and also what's known as craniosynostosis, or where the skull sutures are overlapping and not allowing for appropriate brain growth. And of course, then we know about the tooth manifestations. Now let's look at it in adults or in adolescents. Again, the same buckets. So again, telling you that this is a continuum of disease severity and spectrum. And then looking at it in adults, the same: skeletal, renal, dental, muscular, and disease burden. So again, to tell you, this is beyond a bone disease. There's much more that's happening with individuals with hypophosphatasia. We recognize this and we really need to help our families out. So again, it's affecting more than the skeletal system. I'm trying to say this in different ways to each one of you because I think sometimes you as patients need to be the advocates for yourself in telling your clinician or whoever's taking care of you that there's more going on with me than the bone manifestations or the fractures or the tooth loss that you are seeing. So in terms of going from there, what do we do when we see someone with hypophosphatasia? Of course, after you diagnose an individual, I think we've really got to do different kinds of assessments. And I don't want to go through this much in detail, but just to let you know that there are guidelines at this point, which myself and a team of us have all worked together in trying to come up with what we say is a consensus, so you can present this to your treating physician. How do I assess for bone health? How does one assess for respiratory or breathing function? How does one assess for growth in infants and children? How do I assess whether my child is growing well, what the physical function is? So these are all available, but this is more for you to be aware that these exist, and these should be done to monitor disease progression or the response to treatment if one is put on enzyme treatment. There are also tools to look for pain, for the challenges and the quality of life that children are facing because of hypophosphatasia. And then similarly, there are tools for adults, again looking for bone health, muscle function or musculoskeletal function and mobility and quality of life. And then there can also be some tools like measuring how long does it take, or how do you really walk if we were to standardize it over a period of 6 minutes. I don't know how many of you have experienced this, but it needs to be done in a very, very systematic way where it's done keeping the cones a certain distance that has to be done each time. So as you can see here, if this turning around, it can be set at 30 meters, it can be set at 25 meters or 35 meters, and if we vary this, then it's going to change the endpoint or how many meters the individual was able to walk. And thus, once again, it's important that this is done by physical therapists with experience with hypophosphatasia or muscle disease. Again, these are just tools for all of you to recognize are needed to help monitor our individuals with hypophosphatasia. So now let's go back down to memory lane. Before the advent of a treatment for hypophosphatasia, let's look at the natural history in neonates and infants with hypophosphatasia. And I think this visual just shows you the involvement of bone. And when we look at these repeat x-rays in an infant from birth to 7 months of age, you can see that there is bowing of the femur, there's a widening of the growth plate. This is the metaphysis of the bone or the growth plate. And then you can see that the bone is not appropriately mineralized. And so this continues to progress and then can lead to ultimate fractures. Of course, also to, as you can see, the bowing results in challenges to this individual or to this baby, and can also result in inability to walk or fracturing when the baby, if this baby is able to walk. Now let's look at the most severe end of the disease spectrum, and you can see that not only is it affecting bone health, but it's also affecting survival rate. And you can see that over a period of time, there's actually a loss of life. Neonates and infants with this have dramatically reduced survival rates. And this is from a beautiful study that was published and was helpful when treatment was being developed for hypophosphatasia. It would not be ethical to put some children not on treatment and see how they would do, as one would compare it to children who were placed on treatment. And this is where these kinds of natural history studies are so very important. Now let's look at it in adults with hypophosphatasia. You can see that from 47 years old, this is an example of a patient, to 61 years old, there's so much more going on in terms of more fractures, more need for intramedullary nails, now involvement of additional bones, and poor wound healing, development of pseudofractures, distal to the site of the old fracture, and I can go on. And then I think for many of the adults, one definitely can relate to this, is often the slow to heal metatarsal stress fractures, feet hurting, feet fracturing, when you walk with barefoot, intense burning of the feet, etc. So again, for us to recognize that it is a continuum of disease, and this was the natural history without the advent of more definitive treatment. Now let's talk about the disease impact further in adults with hypophosphatasia. This is a study that was published, of course, with many others, but this was based on 2 patient-reported surveys. And this was a paper that I was involved with along with my colleague, Dr. Weber and others. And here you can see 86% of patients with hypophosphatasia, and this is using 125 reports from these patient surveys in adults with hypophosphatasia, that patients had experienced more than 1 fracture. Now, the mean number of fractures over the lifetime of these adults was close to 13 fractures. But if you look at the range, there were some adults who had up to 100 fractures. 36% of them had non-healing fractures, and many of them, about 40%, experienced their first fracture during childhood. So really, I don't want us to minimize the extent of disease involvement in individuals with hypophosphatasia. And then many of them reported pain and impaired mobility. So 95% reported severe pain. Many of them reported the need for mobility assistance using an assistive device or using an assistive device to walk, or is currently using a wheelchair. So about a fourth of our patients who completed the survey actually said that they needed a wheelchair to work, to move around. Of course, then, in terms of even quality of life, descending stairs, the ability to climb downstairs, 81% said that they had difficulty with this. Standing from sitting, more than half said that they had difficulty. So clearly, I think for us to recognize this and use this as monitoring of a response to treatment, I think is very, very important. And now I want to again come back full circle. Remember, we talked about the 6 subtypes of hypophosphatasia. Often in the literature, we talk about odontohypophosphatasia. And so this is patients with manifestation limited to dental symptoms are classified as having odontohypophosphatasia. I really want us to rethink this, and we published this along with my former trainee, Dr. Mari Murray, of a case series of individuals who were reported as having just odontohypophosphatasia. And really, is this a misdiagnosis of childhood or adult onset hypophosphatasia? A call for a long-term follow-up of premature loss of primary teeth. I think many of you will relate to this, that you started out with what was called odontohypophosphatasia, lost to follow-up, and then came back later with bone pain, fractures, and then sometimes, a full-blown manifestation of hypophosphatasia. So this is again trying to go beyond what has been called, and truly, what is the definition of odontohypophosphatasia? How many of these patients who were called odontohypophosphatasia really had, more than tooth manifestations of the disease? Now let's talk about the management of individuals across the lifespan. So again, this is to let families know, to empower you when you go and see your treating physicians, your pediatrician, your internist, that there is monitoring guidance for patients with hypophosphatasia. And this was again done with a number of colleagues in the field. And this serves really as a way to get the much needed help at remote sites or at centers where you're unable to go to a center with experience and expertise in hypophosphatasia. And so now let's go to the fun parts of what we've learned through the years. Before 2015, so before there was a treatment for hypophosphatasia, we talked about what we were doing, what was the natural cause of patients. Many ended up requiring a bone marrow transplant, or treatments have included bone marrow transplant, the use of parathyroid hormone, untargeted enzyme replacement therapy, and the use of bisphosphonates. Now once again, this I want to pay a little bit more attention because this is relatively contraindicated in someone with hypophosphatasia, because it is what we call a synthetic analog of inorganic pyrophosphate, exactly what we don't want to be administered to someone with hypophosphatasia. So now let's move forward and say, where are we today since 2015? And it's available, as you know, it's called aspartase alpha, or the commercial name is Strensiq. It's available as an 18 milligram, 28 milligram, 40 milligram, and 80 milligram vial. Again, I want all of you as patients to advocate. So if you are a 38 kilogram individual, please do not have that 2 milligrams discarded. Please try and use the vial in entirety. Once again, a message that I think is important to give. The medication is expensive. There's no hard and fast rule that we have to just stick with the 1 milligram per kilogram 6 days of the week or 2 milligrams per kilogram 3 days of the week. We have to work with what works best for individuals. So for some who have a weight over 80 milligrams, we've used up to just the 80 milligrams. Or, we've modified as needed. So again, once again, work with your treating physician and see what works best in terms of a combination of these so that you are not wasting expensive drug. Okay, so now what really is aspartase alpha? It really is replacing what is missing in the body, which is the alkaline phosphatase. So once you replace this alkaline phosphatase, you can really get this hydroxyapatite crystal formation, calcium and phosphate binding together, and you can now get improved bone health. So when you think about the work which goes into the development of a treatment, there are many more trials beyond this. I'm just going to try and point out how much has been done to get this treatment to where it is. And you can see how the work started, and we were part of what we call the first phase of the studies, or phase 1 of the studies, where it first started with intravenous use rather than the subcutaneous use. And then from there, trying to get the optimal dose where you have both safety as well as efficacy for individuals with hypophosphatasia. So this is really what the impact of treatment is, where you really see hypomineralized to now an improvement of mineralization, and in some instances you can actually visualize the bone, which wasn't even visible earlier on. You see an improvement at the level of the metaphysis or the growth plate. You can see here, it's still not ideal, but there's an improvement. And then I really want to again point out to the 6-minute walk test and monitoring of adults. Of course, we can see the fractures, we can look at bone density, but we need other ways from a functional perspective. So this is one of the patients who was seen at you, and as you can see these cones here, these are placed at 30 meters apart, and I want to show you from baseline to year 4. The patient started out at 260 meters, that's the patient who was able to walk over 6 minutes over a period, and then was able to do 461 meters. So you can see like close to doubling, and this is in terms of what we say is percent predicted. So this was a 52% of percent predicted, so not doing as well as then being close to 100% of what one would expect someone at that age and gender to do. So I think looking at things is worth a million words. So you can see here how much different the patient is walking in terms of the speed, but also in the quality of the gait. More unsteady here, more steady there, and also less of the side-to-side movement as compared to here. So once again, I think these become important ways to monitor our individuals with hypophosphatasia. Okay, so in addition to enzyme treatment, we definitely have other supportive measures, and this can include treatment of high calcium levels by restricting it in the diet, so the important role of the dietitian, using medications that can inhibit calcium excretion because we don't want, the nephrocalcinosis of the stones, using vitamin B6 for seizures, surgical relief for the craniosynostosis, dealing with the orthopedics for fractures or pseudofractures, optimizing this for our patients before they go in for surgery, going to the dentist for dental hygiene, use for pain management, such as the non-steroidal anti-inflammatory drugs, etc. And again, in addition to the general following of management, I want to again tell you that we have physical therapy guidelines that are now published for individuals with hypophosphatasia. And this again was team effort, as you can see with Don Phillips, myself and others, who worked on this to try and get physical therapy guidance for hypophosphatasia, which can include standard outpatient physical therapy, management of mobility devices, management of orthotic devices, and evaluation of the environment to support safety of the individual with hypophosphatasia. So I definitely would encourage you to work with physical therapy as needed and in many, many different dimensions. So now we have entered into an era of treatment with aspartate alpha, but there are challenges with the treatment. Many of you have experienced these. We often hear from our patients directly, from individuals from soft bones asking for help for patients. The most common, which is also on what we say the package insert of this medication Strensiq or aspartate alpha, is the injection site reaction. The second is a systemic reaction. By this I mean it's going beyond the site of where the injection was done with the aspartate alpha. It's now a more generalized reaction where the patient is experiencing fever, chills, generalized rash, to the point where it can also result in swelling of the tongue, in difficulty in swallowing, in choking. It's almost like what we know it as anaphylaxis, like a response to a bee sting. So these can occur with any kind of replacement protein such as aspartate alpha. And then also the ectopic calcifications. Ectopic means outside of where we want it, and in this case is outside the bone. This can occur. If I treat someone with too much of something, can I result in a situation where the bone is being formed, not just the calcium and the phosphorus being laid down in bone, but is it also being laid down outside of bone? I'll try and touch upon these because again, I think pictures teach us a lot. I know many of you have experienced this. So it can just be what we say a redness. It can progress to a discoloration and an increase in the region, and this occurs even when the patients are trying to rotate sites, following the precautions, getting it out from the refrigerator, allowing it to settle, for about 30 minutes, changing the needle, using the right side of size of the needle, rotating the sites to as many as possible. You can still end up with this. Or in the more advanced or more difficult stages is what we call a lipo, which is fat. Hypertrophy is excessive thickness. And so if you have excessive buildup of fat in these regions, you can understand that the absorption of the drug may not occur as well. It also is sometimes a challenge because it's cosmetically not ideal. And so there are remedies and solutions around this which are definitely attempted, but they still do occur. But I think the more significant challenges are when you develop what you say fighter cells or antibodies to the medication. In this case, it is the aspartate alpha. By this, what I mean is that the medication that's administered is looked upon as foreign by the body, and they make antibodies to it. Currently, there's no clinical test available to measure this antibody response. It is being developed by the sponsors, Alexion, but this is more in a research setting at this point, and it's not really clear whether the development of these antibodies are really playing a role. If they're playing a role, is it at a certain level? Is it for certain patients with hypophosphatasia? So much more work needs to be done in this space, and I know that Alexion is definitely working on it. And then I think there's a second challenge which can occur, which I alluded to or talked about, which is these allergic reactions or hypersensitivity reactions to Strensiq or to the aspartase alpha. And we have to deal with this because at this point there's no approved treatment specifically for hypophosphatasia. So again, there are methods for those patients who experience this hypersensitivity reaction, which is a process which is called you desensitize someone. Exactly as the term suggests, you break it down so that now we can go back and treat these patients with this life-saving treatment. And this desensitization does require maybe partnering with an allergist, with an immunologist, again, honing in the importance of team approach. And here at Duke, we have found some ways partnering with the allergy immunology team, trying to work with our patients to ensure that they can go back and receive treatment. And we do have some work that is being submitted at this point, to bring it to the scientific literature so that this can be used at other centers as well. And then the last aspect which I talked about was ectopic calcifications. So we talked about that if you've got low alkaline phosphatase, you have increased levels of PPI. This is inhibiting the normal mineralization, and this may lead to calcium accumulation, low levels of phosphorus because it's still bound up with the inorganic pyrophosphate. So at this time, as we follow patients over time, we do see calcifications that are occurring outside of bone. It's really unclear whether it's due to the disease process itself, because when you see the literature, there are some patients who have never received Strensiq who have this ectopic calcification noted in the eyes, or is this a side effect of Strensiq? If you overtreat someone with Strensiq, if you reduce or you subject the PPI to very, very low levels, are you going to result in now more of what we say the ectopic calcification? So this comes back. It's important to monitor how we are treating our patients. We're looking at bone health, we're looking at how the patient is doing, but we also have to look at the biomarkers, the PLP or the vitamin B6 and the inorganic pyrophosphate. So in terms of these challenges, it is part of what we say the package insert, that patients treated with Strensiq have had calcifications in the eye. However, the important thing to note is they have not experienced any vision problems related to these calcifications. And now in our experience, as we follow these patients out more, again to let you know that sometimes what we are noting is that it's either becoming stable or it's reducing. Many of you know that you go for a kidney ultrasound. The reason is really that patients can have some calcifications, what we know as nephrocalcinosis in the kidneys. Now, the unanswered question is blood vessels. There could be some laying down of this calcium deficits, laying down in blood vessels, and so does it result in an increased risk for coronary artery calcification? Not really known. So we need to really collaborate with our vascular specialists, our cardiologists, to learn more about this, again, to monitor and do the right thing for our patients and their families. So this is all ongoing work, and this is a publication from Duke in collaboration with our colleagues in ophthalmology, and this really is showing you these calcium deficits, as you can see, that are laid down. And by looking at the biopsy, it was confirmed that there was this calcification in these patients. Again, I don't want to send any alarm bells because it's not resulted in any challenges in terms of vision, but it's something that we need to look into further and monitor. So this is really what it looks like. When our patients have come to clinic, we try and look for this, and this is, as I said, the biopsy which was done and which showed it. So now coming back, how are we going to learn more? We have a life-saving treatment, we have new treatments in development, second-generation treatments, gene therapy, as you heard from Denise. So how are we going to collect this information in a real world? I don't know how many of you have participated or heard about the HPP registry. This registry is available, and you can see this on clinicaltrials.gov. Again, this is a site that I would suggest all of you have, teach yourself to look at. It's clinicaltrials.gov, and you can find what's new, what's going on in the field of hypophosphatasia. And here you'll also find more about the HPP registry. How do I get involved? I can tell you, you can speak more to Erin, you can speak more to our center, to Softphones, to other physicians, other experts in the field. And why do we have a registry? It really gives us an idea to learn what's going on in the real world beyond clinical trials, because clinical trials is just a tip of the iceberg. It's certain criteria that were met for those patients to qualify in the trials. But then what happens to the rest of us, the rest of the patients? And so we learned diagnostic delay is common among patients with hypophosphatasia. Initial findings from a longitudinal prospective global registry. So once again, you can see team effort from across the world. Then what is the real world clinical profile of children and adults with HPP? The burden of illness. All this helps us, educate ourselves, be more advocates for ourselves, but also help you patients out more to help you, to help better the care, and also as next generation treatments are developed, to understand what is the spectrum of involvement. So this HPP registry, I think, is a very important forum for us to learn more from you. And so in terms of future directions, I can speak to what we are doing at our team here at Duke, monitoring for these calcifications, also from the vascular system, from the heart, with an expert metabolic cardiologist, trying to look for management of these IgG and antibodies, and then what can we do to help these patients. I've collaborated with a physician in Spain who has a little baby who had problems with these IgG antibodies, and we've had some success. Management for those who have these hypersensitivity reactions. We've got something coming out soon on this. Then collaborating with experienced surgeons to better understand the impacts of surgery. What is the right time? What is the kind of surgery? What do we need to do? Collaborating with physical therapy on the musculoskeletal aspects of hypophosphatasia. Collaborating with our dietitians. What is right for our patients with hypophosphatasia? You'll hear more about this from a dietitian who's speaking today. Continuing to investigate what happens when someone is diagnosed with hypophosphatasia. How does it impact other family members? Are there different modes of inheritance? So for instance, there could be a baby with hypophosphatasia, but there also could be an adult who's not just a carrier, could also be affected with hypophosphatasia. More of this will be from the talk by Erin here. And none of this really would be possible without the dedication of you, the patient, and your families. And so I want to close by saying that coordination of care, please build your team, and the most important member of your care team is you, because you have to be a self-advocate, you have to partner with the rest of us, and this team approach, a collaboration, because one size does not fit all, and understanding that even if I am a physician working with you as a patient, I am incomplete. I am not doing you justice if I do not collaborate, if I do not work with others to ensure that you are getting the best possible care. And so this is our team. And once again, I want to close with a thank you for your attendance. Thank you to Softphones for organizing this meeting, allowing our team to participate. And as you check out, please remember to check out the exhibit hall, lounge, and the resource center.